good afternoon, everybody. I know we'll have people wandering in, they always do, but we should be okay. Now that we've had our earlier training by the fire department, I have to start the meeting slightly differently by reminding you, because there are some visitors here who haven't been here before, we have 3 exits from here if there's any reason to evacuate, which will never happen. We have our door here, there's a doorway back there, and there's actually a back door. You go out the back door, you turn right, and you're heading out. And I guarantee you, if such an emergency occurs, someone will be out there to guide people how to continue further on. And I'll do that myself, because I doubt very much if there's going to be a problem. Now, this meeting is presented by MACRA, and we're delighted to have Dr. Terri Hill here to speak, who most of us know, and the topic is a fascinating and terribly important one in terms of where are we future-wise in terms of the struggle to get affordable health care. And it's a very important topic, right on time, in terms of issues on everybody's mind. I have to remind you, since this is a MACRA meeting, that the discussion afterwards will stay within the general confines of healthcare, or anything else you'd like to ask Dr. Hill. But please try to stay away from issues relating to an interesting phenomenon coming up very soon, called an election, because we do have to protect our status as a nonprofit, nonpartisan, kind of organization. Although I doubt if anybody agrees that we're nonpartisan, but anyway, we'll just have to let it go that way. And everyone's comfortable, good. Let me turn it over to Dr. Hill, who is much more interesting to listen to than me.
All right, thank you. Thank you very much. Good afternoon, and thank you all for coming out. Let's get that out the way. Healthcare, obviously a hot topic. Most of you, I presume, are on Medicare, and so in some ways your health care is a non-issue unless you're a state retiree who suddenly found your prescription drug benefits get switched around. I see some nods, right? Unless you have a secondary health insurer and need things like hearing aids, dental work, and those other things. And you may also, some of you probably have a pension with some health benefits as well. So the reality is that our healthcare system coverage is a very, very heterogeneous system. And as you guys know, federally and at the state level, we've been struggling for at least the last 10 years very deliberately at trying to see how we can expand coverage and at the same time make it more affordable. And so there are lots of ideas that are being played at. And just so you know, the idea of a single payer system is not just limited to the federal level. We've had several bills, and there are a couple bills coming through the House and Senate in Maryland this year to try and get us to a single payer healthcare system in the state. One of the issues with that, and I was just talking with, tell me your name again? Jans, who worked with Shane Pendergrass, who's my chair on the Health and Government Operations Committee. And Shane had said to me when we talked about this a few years ago that it's really impossible for a single state to go with a single payer system because there are just too many other issues. But one of the delegates, Kirill Resnick, introduced legislation 2 sessions ago that actually was pretty promising. And one of the things he said is, actually Maryland's kind of in that perfect position because we have so many people who are already on Medicare, so many people who are already on veterans coverage, so many people who are already on military TRICARE, so many people who are on federal coverage anyway, that you're talking about a very relatively small group of people who are on private commercial insurance and also people who are on Medicaid. So when you look at all those groups who are somehow getting some type of federally covered insurance, it gets down to a really small number. And so the bill that he introduced, and he's reintroducing this year, looked at the MCOs, the managed care organizations, and said, let them be the folks providing the care. And then after a few years, let them bid out to be a single provider. So, so that is part of the discussion we're having in Maryland, even though people think of it as a national issue. What we found with so let me sort of give you some background. When the Affordable Care Act came out, it had mandates, right? That every health insurance policy had to cover. And Maryland back in 2011 or so filled on that and decided what our required plan would look like. We just had a briefing on that yesterday of what that costs per month for people on an individual market, a single payer market, a small group market, and a large group market, and it ranges per month for individual between $400 and $500 a month. That doesn't sound really affordable. But that's with all the benefits there. So, and every time we choose to expand the required benefits, it actually costs the state. So there have only been about 3 things that we've expanded on since that initial setting up of what our program looks like. So what we're struggling with now is the reality that we want to extend access, and the ACA and frankly the Medicaid expansion increased access, meaning coverage, by several thousands of people. And we're down to a fairly limited number of people who don't have access. But access, meaning you have insurance coverage, doesn't mean you're seeing the doctor. Because as premiums have gone up, or the premiums have come down, the co-insurance, the co-pays, the cost sharing has gone up. And so we're still seeing, even as we did during the recession, people who are saying, I know I have insurance, but I don't want to put that $50 out. I don't want to, put that extra money out. So let me see if I can get away with not seeing anybody. So we're not actually seeing the access, and particularly the kind of access preventive care that is supposed to save us money in the long run. Prescription drugs are a whole nother thing. And I'm gonna sort of segue it a little bit off of strict health care when I talk about prescription drugs. One of the things we're trying to deal with in Maryland and across the country is this opioid overdose and opioid epidemic, right? And there are lots of ways to look at the problem. So we've got more and more people who are addicted to opioid and other class 2 medications, barbiturates and things like that. And it's causing all kinds of problems. Suicide rates are going up, work productivity is going down. We're seeing all kinds of ramifications of that. Now, most of you will remember that before there was an opioid epidemic, there was a methamphetamine epidemic, and there was a crack epidemic, and there was a bath salts and a PCP, angel dust, and there was a heroin. And my point of saying that is we're all focused on the opioids, but we have an addiction problem. We have an addiction problem. And in my opinion, whenever we get focused on the drug du jour, right, the drug of the day, we don't really start looking systemically at what is the problem and how do we deal with it. So the opioid epidemic has primarily been dealt with at the federal and the state level from supply side. So we're looking at ways of decreasing the amount of narcotics that are prescribed. We've put systems into place so that pharmacists and physicians and other prescribers now have to query through an electronic system before they write a prescription for a Schedule II medication or barbiturate or an opioid, and find out what is the history of that patient. How many prescriptions have they received in the last several months? How many pills did they get? And we're looking for people who have who either a drug seeking habit or who have a high rate of use and may have an addiction issue. And we're not, as a physician, we're not required to do anything with that information. We don't have to say, you know what, I saw that you had 30 of these pills just 2 weeks ago, therefore I'm not going to prescribe it. But we're supposed to be cognizant. And the state has been trying for several years to turn that cognition into a means of identifying the outlier prescribers and looking to prosecute them for potentially being pill mills. The problem that has created is people who have chronic pain, who have real need for pain medication, are now finding it really difficult because the doctors and nurse practitioners, other folks have been so scared in some cases that there really is no differentiation between the person who really needs the medication and the person who probably doesn't. And so it's made an interesting legislative tug of war. And for me as a physician, I think that there are things that we need to look at that go a different way. For instance, we passed legislation, so 2015 or I think 2016, that required Narcan, which is an antidote to opioids, to be made available to all first responders and to persons who are using narcotics, whether they're using it for medicinal or for recreational purposes, and for their family members. So if someone has an accidental overdose, we can all get trained and deliver the Narcan and save the life. Well, as soon as we did that and multiple other states did it, the price of the Narcan shot way up, right? So we all heard about, some of you are economists, supply and demand. It was supposed to bring the price down, but it didn't. 4, 5, 6, 7, 8 times what it had cost before, okay? Similarly, if you think about it, we've identified certain companies in the big farm industry as being complicit, if you might say, in helping to roll out these medications with false information to the prescribers about the addictive potential, and playing a role in where we are with narcotic addiction and problems. Yet we've also passed legislation, even in Maryland the past several years, to certify medical treatment facilities for addiction, which are important. These are facilities where people can go and get Suboxone and some other new age medications to break addiction, but they require maintenance. So they're not very different from methadone, except in how often you have to get it. So instead of methadone, you have to get a pill every day. With this, you can be given a shot, it can last for a while, but you have to be sustained. So we're now financially rewarding many of the companies, or at least the industry, for helping to create the addiction problem by allowing them to profit over the treatment of the addiction, right? So from my standpoint, we've got a real problem with how we're approaching that issue, right? So we may be not medicating people who need to be medicated. We're financially rewarding people who pay very little penalty for being part of the process. And one of the bills I can tell you specifically that I remember looking at, and I think my perspective as a healthcare provider was a slightly different lens than my colleagues on committee looked at. We had a bill that said that you ought to require that all insurance companies in their formulary, which is the list of medications that they agree to pay for, include a narcotic that can't be smashed. So a really hard pill that you can take, but you can't crush it. The theory was from the pharmaceutical company that if you can't crush it, then it's harder for somebody to snort it or to do anything else with it, to use it as you would if you were trying to get high. But what it said to me is if they can't crush it, that's going to send people out to get the heroin. It's going to send them out to get the street drugs. So if you think that addicts are choosing to take medication as opposed to being compelled, then that's great. You take away the choice. You can't, it's so harder for you to do it. You're going to go home and just not get high. But that's not what addiction is. So if you can't get it easy, you're gonna get it any way you can. And it actually pushes people out. So I think it's a really complex problem. I'll be happy to answer questions about the other solutions we're looking at. But what we're missing is, in my opinion, the underlying behavioral health component. So yes, addiction can be triggered by exposure to addictive medications. We know that. But we also know that the vast majority of people who are given a prescription in an appropriate setting for a narcotic do not become addicts. So yes, the majority of people who become addict will say, I was exposed to a narcotic first following a medical procedure. The corollary does not hold that the majority of people who are exposed to a narcotic following a medical procedure become addicts. So that doesn't hold. So there's a disconnect in there. There's something that we have to look at. And I think, frankly, that part of the problem is that physicians, nurse practitioners, and others, we're taught how to prescribe medication. We're not necessarily taught how to get people off. So if you've had orthopedic surgery and you're on oxycodone or something for 2 or 3 weeks, that may be an appropriate medication, but we're not really taught, if it's been 2 to 3 weeks, do you have a dependency? How do I tell you to taper? So usually what we'll say is, you don't need it anymore, your prescription's over, stop taking it, right? That doesn't help. And so I think non-legislatively that we have to be trained better about what that looks like. And there was this wonderful, I don't know the guy's name, there was a physician out of Johns Hopkins who about 3 years ago wrote an article and then did a radio piece where he talked about having a horrific car accident and being put appropriately on some narcotic medication. And after being on it for many, many weeks and still having a great deal of pain, thought he was seeing some symptoms of addiction. I think it was some stomach issues when he tried to go longer between his doses and what have you. And he went back to his primary care first and said, I want to get off. And his primary care said, I don't know what to tell you. I don't do that. Go talk to the orthopedist. And the orthopedist, who had been prescribing the medication, said, well, go see a pain medication doctor. And the pain doctor said, well, we prescribe how to get on, right? We don't wean people off. That's an addiction specialist. And in the end, one of the doctors said, just cut your dose in half, and 3 days from now, cut it in half again.
Well, you know what's so complicated?
What do you say?
I say, what's so complicated about that?
Yeah.
I mean, anybody, you have to dwindle the affect you.
It takes less of it every year. I mean, my primary care physician has told me that.
You wean yourself off.
Right, but it's not cut a dose, or it's not when your prescription ends, you just stop taking it.
No, you have to do a little.
But there is a process, not a big learning thing, but if you don't know how to instruct, then you don't know how to instruct. So I think we're contributing to the problem, because we do put people on medications and don't say, you know, okay, after 4 or 5 days, I want you to go from 2 pills, I want you to try 1 pill, I want you to supplement with a little Tylenol and see how that goes. If that doesn't go, give me a call back and we'll talk about switching some other things. I want to add a little naproxen, or we don't really go through that. Here's the prescription, you take it. The other thing that happens is we don't deal with that other group of people, the people who try to get high, whether they're naive about the narcotics or not. So whether it's a 14-year-old who goes to their parents' cabinet to look through some pills to take to the party, to share, or it's that demographic that is our fastest rising group of opioid overdose victims, which are the white males ages 45 to 55, right? What is motivating folks? Is it avoiding their life? Is it feeling like they're being left behind socially and economically and don't have an outlet? What is it? Behavioral health, meaning addiction medication or addiction treatment, and frankly, good old-fashioned psychiatric treatment are things that we just don't do enough of. We don't do it early enough. So the General Assembly has been working really hard in the past 5 years to recognize that we have kids who are dealing with greater and greater stress, coming from stressful households, sometimes really stressful situations, and we don't have the supports for them in school. And we passed legislation 2 years ago to require that every school jurisdiction have a behavioral health outreach specialist who begins to coordinate that care. And when we do our community schools, and I can explain, community schools are schools that don't just teach kids, but they become a resource for the community, and they're assigned a person who is responsible for assessing the greater community needs and trying to make sure that to the extent possible they're filled in the school. So for instance, if it turns out, and we've seen this where there's a community where there's no dental care, even though it's a school, they'll arrange for the dentist to come in and see not only the kids, but maybe in the evening see the parents too. If there's a need for, we've heard of community schools where they put washers and dryers in. And I've even heard of schools where they use the washer and dryer as an incentive to get the parents to spend an hour every few weeks in the school. For every hour you spend working with the teachers, we'll give you free laundry services, right? So community schools are about saying the schools are where the kids are, and that's where we have to put the resources and all the wraparound service. And it helps the school to be respected and valued in the community and become a center. And it's a way of recognizing that some of the things that we've seen over generations that are impacting our communities, we can't go back and fix at the parental level, but we can invest at the child level and bring folks along. So one of the things that almost all community schools have to have, they're finding, are more school counselors, not guidance counselors, but actual counselors, and psychiatrists and psychologists and all of that stuff, because kids carry an awful lot. And I know in my practice, for those who don't know, I'm a plastic surgeon, but I will tell you, all socioeconomic levels, I see a lot more teenagers coming in my door who have medications that they're taking than teenagers who don't. And whether it's, the stress of performing academically or competing or whatever else is going on, it's not really clear, but we're sort of failing. And so when we talk about addiction and what is the demand side versus the supply side, the question becomes what has happened in our society and our communities that are feeding this need to escape in ways that it didn't do before. One of the things that I've worked with Delegate Wendell Beitzel, who's from Western Maryland, happens to be a Republican, I happen to be a Democrat, is we both discovered through constituents and anecdotally that there's a drug called ibogaine that was researched initially back in the 1990s. And it had some pretty promising results. It seemed to be able to break addiction without the need for sustained use. There apparently in some of the research, there were some cardiac complications, which as a medical person, I would say usually mean you start playing with the dosage and figure out if there's a better dose or how you administer it. But somehow it was removed from Schedule 2 to Schedule 1, which means no redeeming medical value and not to be researched. And so when I looked into this 3 years ago, and as he did, what I found out, my suspicion was Big Pharma must have not wanted this drug out. And I spoke to someone who was in the federal government at the time. Actually, he heard me speak and he sent me a note saying, "You're not far off." It was big tobacco. It was big tobacco. So right now that's just rumor, but this medication is there. There are a few practitioners who will take patients out of the country to administer it. There are people who will take their kids to Mexico or to other places to get this drug. And what we hear anecdotally, which is not fact and science, is that it is successful. It is a hallucinogen. It requires a certain amount of care for about a week, but that people are seeing sort of release from the urge of cigarettes, alcohol, and drugs for 6 and 12 months without a second treatment. Right. So for me, the question is, even if it proves to be wrong, if we're saying we're having a crisis, how can we not even be doing the research to find out if there might be a subset of people for whom this would be effective. And I'm cynical enough to believe that the reason we're not doing that is because it's money, right? So I guess my point is that healthcare takes on so many different tones. When we talk about, violence in our community and gun violence, we just passed on to a final vote, probably on Monday, our long guns legislation, which is trying to close a loophole in Maryland's law that would allow me to transfer a gun to, say, Michael here, without him going through a background check, because it's a one-on-one transfer. And so we're going to try and get that loophole closed this year. And what we've heard from the opposition on the floor is that, the real threat are handguns. That's the threat out in the community. That's where the violence is. But again, the data shows that when we talk about domestic violence, and particularly women who are killed by their estranged partners, particularly when they're trying to leave, it's long guns. When we talk about suicide, it's often long guns. So they're not benign. They're not benign. And I guess it depends on whether you're focusing on stranger violence, and if that's your greatest fear is you're going to be assaulted going to a restaurant, then you're going to focus on that, and our laws are pretty good about that in background checks. But if your concern is relationship violence, which is actually pretty huge, and it's more significant in the numbers. It's not as glamorous. It doesn't get the headlines the same way, but it's the real everyday problem in all of our communities, right? No matter racial, ethnic, religious background, no matter socioeconomic class, that's the real danger, especially for women, right? So it's a different animal, but again, that and other forms of violence, domestic violence, we're not approaching it from a healthcare lens. And fortunately, in this last budget negotiation, the feds finally put money into research on violence. Where previously, not only were they not putting money in, they absolutely prohibited the federal money to be used for research on violence and gun violence particularly. It doesn't help if we don't want to look at the problems and come up with solutions. So that's sort of what the healthcare lens is, where we have, we passed a bill last year that's going to go into effect for the next tax year, for the 2020 tax year. That doesn't necessarily affect many of you, but it sure affects your families, your kids, and your grandkids. And it basically allows for a box on the Maryland tax form for people to check off if they say, I didn't have insurance. I didn't have health insurance in the last year. They can check off a box that says, but I really would like help finding out if I can afford health insurance. And with the information the controller has collected on that tax form about their income, etc., it will be plugged in, and these navigators and people at the state will look to see if they qualify for any of the health care plans and for the subsidies that make health care affordable. And they check another box that says, please contact me. And we really think it's going to make it easier for people to get health care. And we think it may actually lower our numbers by another 50% of uninsured. From a prescription drug standpoint, last session we finally successfully passed the Maryland Prescription Drug Affordability Commission. And as introduced, what that would have done would have allowed this group of folks to review drugs that have had an increase in cost over a certain threshold and ask the manufacturers and the pharmacy benefit managers to justify why they're charging what they're charging. And if the commission found that those charges were out of what one would normally expect, they would then set a fee and say, no one in Maryland can pay more than this amount. So if they were charging $200, we'd say, no one in Maryland can pay more than $50 for this. So if you're providing insurance, $50 is the max you can pay. So there was a problem with that bill, and I'm very pleased that the amendment that I offered fixed it. So let me first tell you why we needed to do that. So 3 years before, we tried to set up a commission. We passed it out of the House and the Senate. The governor, I don't know if he signed it or not, but we passed this commission. I think he didn't because he thought it wouldn't, I don't think the governor signed it. But it basically said we're going to review this stuff and we're going to tell the pharmaceutical companies you can't charge more than a certain amount in Maryland. And the court said that's not constitutional. They're interstate commerce laws and you can't tell somebody what they can charge. So they came back again last year and said, okay, we'll review it. We won't tell you what you can charge. We'll just tell you what we'll pay. I said, okay, because that's our option. So when the bill was presented last year in front of my committee, I got to tell you, we questioned, it's bipartisan, and I just kept looking at the people for the drug industry, and they had this smirk on their face. Like they just knew this wasn't going to work. And I came back and I thought about it, and I thought about what rules as practitioners we're allowed to do with charging. So if I take Medicare patients, I can charge, let's say for taking off a mole, I can have a range of charges. I can charge Blue Cross this, I can charge, somebody from Aetna something different, just like they pay different amounts. I can decide, that somebody who's a resident of Vantage Point, I'm gonna charge them differently just because I like you guys. I can charge what I want, but the rule says that you can't charge a Medicare patient more than the person you charge the least. Right? So I went back and I said, I don't think we as a state can tell Aetna and Cigna and CareFirst and Kaiser that they can't pay more than a certain amount. But the state has health insurance on thousands and thousands of people, not just state employees, state retirees, school systems, local governments. So I went to the sponsor of the bill, Jocelyn Pina Melnick, who's our vice chair of HGO, and I went to the advocate, some of you may know Vinnie DeMarco, and I said, we can't do it this way, but if you limit it to what state plans are, what we pay for, we can always say what we're willing to pay. And if you do that, I don't think they'll be able to take us to court. And he said, well, that doesn't cover everybody. I said, it doesn't matter, because once we set that floor, all the insurance companies will negotiate down to it. So we can impact the cost of those medications for all Marylanders simply by saying, as probably the biggest payer in the state, we're not going to pay more for a drug X than this and the other. And that gives the other insurance companies the negotiating room that they need to do the same. So there were some other changes made on the bill. The commission was, appointments were made during the interim. They had their first meeting the first week in January. We're off to a good start. No threats of lawsuits. It'll probably be about 3 years because of certain things that they have to do before we'll see the first impacts of that. But just really, really glad that we're able to do something to try and bring down the cost of prescription drugs. It's a long slog. Yeah.
How do you determine how much you pay for a drug? What is that based on?
Yeah, so the legislation has some complexity to it. It has to do with what the average charge is and why they increase it. And they have to justify the increase. So if you think of the example of the EpiPen, right, which shot up ridiculously. And when the CEO went before Congress, the excuse was, well, yes, the medication's been around for decades and it's generic, but we have a different delivery system. And it would be up for the commission to say that doesn't justify a 10-fold increase. Your delivery system is on patent or it's not on patent, and that's fine. But the reality, when I think about epinephrine price has gone up all over. So even the bottles that I get from my office to mix, that shot way off too. So it wasn't just the EpiPen, right? So there are things they have to look at, and I think what the pharmaceutical companies hated most about the bill is they're required to disclose the information about how they came up with their price. And so we get to peek around the curtain and see what's going on, and that's the thing they really were fighting, right? So it's a transparency bill. And it doesn't affect every medication. The medications really have to have, I don't know, there's a 200% increase within X amount of time. And the question is why did you do that and how do you justify it? Now in Europe, there are countries that actually have prescription drug commissions, cost commissions, that will look at a new drug as it enters the market and will assess how much more value does this drug have to whatever else is on the market. And they will give it a grade, and the relative price increase of the new drug will be based on that. So, if you've got aspirin, and then you introduce ibuprofen, and they're essentially for the same thing, the question becomes, okay, ibuprofen's new, but what is it adding to what aspirin already does? And what is the value of that? And then if Celebrex comes out, and then Naproxen comes out, and then another and another, so you don't get to just have a higher price because you're the newest thing on the market. You actually have to have value. In America, FDA talks about whether you do what you say you do and have a relatively low risk profile, but they don't talk about whether you have added value. That's not part of our system. And it may be that that's exactly one of the things that we should have to look at. Because the problem when we only focus on how we're going to pay for healthcare, and again, let's focus on drugs. So whether it's going to be a single payer, whether it's going to be some other model, whether it's going to be a public option, or whatever. Frankly, they don't care how they're getting paid. They don't care who pays them. They're still getting paid. So whether it's the government, whether it's a conglomeration of independent health insurers, whether it's you coming out of pocket, they're still getting paid. And most of the discussion we're having, both at the state and the national level, is not about how do we have reasonable costs to prescriptions and other kinds of health care that respect the need for the industry to be sustainable and to have some profit, but really do away with the gouging and I think the exploitation that some of us really feel is present in the system. And so until we figure out how to approach those aspects, right? And we don't even do that with gasoline, right? So the price goes up of oil, and we've got anti-gouging laws. So if you go to the gas station, you don't want to see it shoot up so much. But we don't have a real sense of, well, what is gouging exactly? When is a price increase acceptable, and when is a price increase profiteering? And those are the kind of questions. If we talk about sustainable communities and how we move forward as a state and as a nation, those are the kind of questions sooner or later we're going to have on some real, I think, deep level. Yes?
Yeah, do you see at some point, do you see at some point, either at the federal level or at the state level, that legislators or the government will begin to look more at long-term care issues, respite, caregiving, all of those?
Yeah, I mean, that's a great question. So, absolutely. And what I hear from you all as constituents all the time, particularly, is about memory care and the fact that that's not a covered service. And I think it's going to be really important. And we've looked at some things at the state level. There is a Alzheimer's Commission that has been looking at the issue and trying to figure out what we have to change in order to allow for it to be covered. And there's some move to change the classification so that it is seen as a somatic illness, which is what it is. And that by changing the classification, that might allow Medicare and other public monies to roll in to treat it. But you're absolutely right, long-term care insurance is a huge deal. And so I know when I look at the federal debates over Medicare for all, I talk about improved Medicare for all, right? So it should include long-term care, it should include dental benefits, it should include hearing aids, it should include glasses, it should include behavioral health. So I really don't want to see Medicare as it is, but I do think it makes sense, right, to lower the age and make it eligible for others, maybe do a public option. So, and then look at how that is and make it better. And that is a way of transitioning to a single payer system that people are discussing. And it's a way of doing it in a way that the cost of a single payer system, I think becomes much more manageable because it's a natural extension of what we're already doing. And by the time you take out of those people's pockets the premiums they're paying, the folks who are buying in automatically see savings. So it's a little less of Peter paying to cover Paul's care. Other questions? Yes?
Thank you, Terri. I'm going back to what you were talking about earlier in your presentation about pills, over-medication, behavioral health, and what strikes me as both a senior and as a patient, really how little information we get from our physicians and how little guidance, systematic guidance, both to changing medications, changing the cocktail, reducing the dosage, and even trying alternate forms that maybe are non-invasive. I wonder if you could speak to that and whether you see anything before the assembly that would promote behavioral health.
Right. Okay, so the issue of what are we doing to make physicians more responsive to their patients and disclose more. So a couple things. Let me just talk about a couple bills that I have this session. One bill, and it's not directly to your point, but I'm gonna get around to it. One of the bills I'm introducing is a partial fill bill. It says, essentially, if you get a prescription and you don't want all the pills, you can get part of the prescription. The pharmacist will keep track that you left some behind, and you can come back in X number of days and get the rest. Right? So you get 30 pills and you're going, I'm thinking I don't want all those pills around my house and I don't think I really need it, but I don't want to have to go back to the doctor and get another prescription, and you're not thinking, well, I better take them, and if I don't use them, I'll throw them away. You can say, give me 15 of them, hold on to the rest. If I find I need it, I'll come back. So we've put that bill in. The insurance companies are like, I don't know, the pharmacists kind of like it. We're trying to look at how you would track it. Particularly with the online physician drug monitoring system where we have the query system. So how are they gonna know that I got, I went to Neighbor Care and got half my prescription, and how do they track so that when I show up at CVS, later on they know that there's a piece of prescription left. And I think there's a way to do it, but where it's really gonna take a little bit of technical working out. So we'll see where that goes. I think it's been introduced early enough in session that we may be able to make that happen. The other thing that again is related, but I'm going to get to it. Last year, I passed legislation to change the way we require authorization and reauthorization for medications, and we're trying to explain for treatment. So you get prescribed, lisinopril for your blood pressure, and you've been on it over and over. What you may or may not know is every 3 months your doctor may have to tell the insurance company why you're on lisinopril. You may go to get your refill and be told by the pharmacist, it has to be reauthorized. Hasn't been reauthorized in a while. Well, that's a delay. It's also a pain. And for the doctors, it uses up huge amounts of time that they don't have to spend. And it was actually Dr. Scott Bauer, who some of you may know, who called me 2 years ago and said, I've had it up to here. They keep asking me the same damn questions on the patients, and I shouldn't have to keep doing that. He says, it's 100 times a day that I have to go in and tell them stuff that they should already know. So I said, well, you want to change? Come on and work with me. And we went through a process and we passed legislation that has become model legislation around the nation. So at the beginning of the month, I was actually down in Florida speaking at the American Medical Association on their legislative agenda panel on reauthorization and pre-authorization. Their interest was also about procedures and things like that, but there was also a physician legislator out of Kentucky who had passed different but similar legislation, and so they had the two of us, because that's the only legislation in the country that does anything. And so what it says here in Maryland is if you're on a medication for long-term care, and that's defined by your doctor. The doctor says, yep, they're gonna be on this long-term. That the insurance company or the pharmacy benefit manager cannot ask for information about why you're on it sooner than 1 year. So this every 6 months or 3 months having to explain goes away. They can't do it any sooner than a year. The second is that the information they already have, what's the page? So this is what we have to do. You have to go in, and either you're doing it manually or you're doing it over the phone, you're doing it on the computer online. What's the diagnosis? What treatment have they had in the past? Have they been on this medication? What was the result? And all this other stuff. What the bill also says, you already collected that information, repopulate it. Don't ask us questions about stuff that you already know. That saves a lot of time. So I shouldn't have to re-justify. In fact, if I write the prescription another time, there ought to be a presumption that I want you on the medication. Right? There ought to be a presumption that if I'm keeping you on the medication, it's because you still need, that your diabetes didn't suddenly go away. You know, that your high blood pressure still requires this particular medication. And it also requires that if the insurance changes mid-year or mid-whatever policy year, that the authorization of your previous insurer has to carry over for at least a month. So you're suddenly not found, I've been on this medication and now I've got to re-justify because this insurance company doesn't carry it on the formulary. So those are the starts, and that's what we've done. And I think that we're looking at a lot of stuff along those lines of how to make it simpler and easier for people. And for the practitioners. It's interesting because I was having a conversation with some docs and some legislators earlier this week, and the conversation was about how the electronic medical record must make things easier. And I was telling them that I don't know a doctor who likes an electronic medical record system. Absolutely hate it. Absolutely hate it. And they said, well, aren't there increased efficiencies? And I said, well, if there were increased efficiencies, we would not have created a brand new profession. There's now a profession called scribe. And the scribe is the person who types into the computer while your doctor, your nurse practitioner, or provider is trying to provide your care. And if it had increased efficiency, we wouldn't have created this new job category.
I have a question, but prior to that, there's also an impact when you continue to require prior authorization. There's an impact on the patient. The patient sometimes in the process can't get the medication while it's being sought out. But my other question is this, or my first question is, it's a quantitative question. Can you tell us a statistic? How many women in the state of Maryland get killed with a long gun? The violence that you talked about. I'd like to get some grasp statistically. How many numbers? What are we talking about?
I can't quote you the numbers, but what I can do afterwards, if you give me your information, I will get that. It's been quoted in the debates on the floor, and so I know the numbers are available. What I remember are the conclusions, but I don't remember the specific numbers, and I don't want to give you wrong information.
Thank you.
Okay. All right. Anybody else? Other questions?
I was interested in the comprehensive schools you talked about. How many do we have in Maryland? What, community schools, is that what they're called? Did that legislation pass?
Oh,
And-
yeah, years ago. A couple years
Yeah,
ago.
right. So how many are there
Yeah.
of schools like that?
I will get you the specific numbers, but I know in District 12, which I represent, Lansdowne High School is one. And we have, I'm trying to think, Talbot Springs may be one in Columbia. I think we may have two in Howard County, but we can get that information and let you know what that is. And because I don't want to misrepresent. But Lansdowne, I know because Lansdowne, for my legislative district, along with Senator Lamb and Eric Ebersole, delegate, and Delegate Jessica Feldmark, is our high school that we have the most need in terms of they need a new school, and we've been fighting for 5 years to get them a new school. And it's a great school, great kids, great teachers. But a week ago, and I know it's it's in Baltimore County, but they, in 20-degree weather, their heater was out. And they got the heater going early on in the day, but it took all day for the place to warm up. And they're holding that place together with duct tape and spit. So that gets to, I'm just gonna segue. So the two primary pieces of legislation, the legislative priorities of this General Assembly, for both the Speaker of the House, Adrian Jones, and the new Senate President, Bill Ferguson, are our schools. It's the Bill to Learn, which is about putting at least $2.2 million on bond into school construction around the state, of which Howard County would get a significant portion of that money. And the other one is the outgrowth of the Kerwin Commission, the 3-year study on how we move our education system forward and make sure that we're doing the things that we failed to do under the underfinanced formula, the previous Thornton formulas. And that Kerwin Commission really did a deep dive into best practices and what works and how do you actually help kids to become college and career ready, and what's needed and where we're failing, and how do we move from being a so-called number 1, 2, or 3 system to moving to the middling of the pack. And it really is about a number of things. It is about behavioral health supports. It is about making sure that teachers get the resources that they need and are financially supported in what they do. But there's another piece to the teachers. I mean, we lose about 50% of our teachers in their first 5 years. They come, they teach, and they leave. And so part of it is about paying them commensurate with their professional skills and level and training. The other is about making sure that they get certain levels of certification. But the other piece is when I talk to teachers, what they tell me is they need to feel supported by the administrators, and they need to have curriculum and ideas for teaching that don't change every year. So that you're working on a track and then you got to do something the next year and something next year. So part of what Curran's also recommending is that we empower the teachers to teach. Yes. That we empower the teachers to teach. And then it's about universal pre-K, which we all know the data shows is the biggest single difference maker in terms of moving kids forward and trying to make sure that we have that for all our 4-year-olds and for 3-year-olds who would not otherwise be able to afford it. So those are the main pieces, and it's a big lift. It's an expensive piece in which phased in over about 10 years. But the question that we have to face as a General Assembly is, what does it cost us if we don't do this?
When we had when we passed the gambling thing with all, wasn't that money supposed to go to education? Does it?
Yeah. So the original, back in 2007, whatever, the original legislation that allowed gambling, there was a slots money, then there was one, so maybe 2011. It did stipulate that certain amounts of funds had to go to education. Some of it also went to the horse racing industry. Some of it also went to other things, okay? So those were the things, but it didn't stipulate that the money that would go in from gambling would supplement. So the lockbox that you guys voted on 2 years ago, 16, that was the lockbox. It said you can take that gambling money, but what was happening is they were saying, well, now that we've met our needs, we'll take the general fund money that we would have put in education and we'll send it somewhere else. So what the lockbox says is, no, you still have to meet the general fund obligations and you supplement it with the gambling money. So that will help, and in fact, we have already funded legislation that we passed last session, the first 3 years of Kerwin. So the first 3 out of 10 years we've already funded, okay? But we've got to figure out how to do the rest. And what's really interesting is we're having a number of issues in the state that I want to spell out. So we get back to healthcare. So there were increases across the board for state employees, except the ASME or the union members, rather than go up 3%, they were held to 1%. We've had problems getting sustained increases for direct care providers. So the nurses and the nurses' aides that help us to stay in our homes, and help our kids to stay in the homes when they have developmental disabilities, their raises are not going up as they should. And that is a group of people who you want to be reliable and trustworthy and consistent, and there's constant turnover because we don't pay them enough. Our prisons are having a really hard time with corrections officers. They now have mandated overtime because they're so short-staffed. And our psychiatric hospitals and psychiatric prisons are also thoroughly undermanned, and you may have seen stories recently about the increase in violence and the risk to those employees. So I'm going to get political right now, because I'm going to tell you that the governor's budget talks about tax credits and deductions. While we're trying to fund schools for a future, while we're trying to hire people for our hospitals, direct care, for our prisons, and for our behavioral health facilities. And I'm cynical enough to know that he's a lame duck, so he gets to get the credit for cutting the taxes. And when the damage rolls out in 3 or 4 years, he's not around to have to be accountable for that. And I think it's really hard because some of the tax credits, man, they're tempting. There are things like, for seniors, housing credits, which we've done a number of years, but it's going to that next, or retirement income, things that we ought to be doing. But there's just something about putting those carrots out at a time when what we're saying is we've got an increasing structural deficit and increasing needs. And that's when you start talking about, let's do some more tax credits. And how do you say to your constituents, we've got real needs and this is not the time to do that? It's tough. It's really tough. Really tough. Other questions?
I might be able to talk loud enough.
You might, but let's not.
Thank you.
And I'm not sure if you can answer this, but I'm going to go ahead and ask it, and you can. But does your experience, not only as a doctor, but in the state legislation, do you think that carries over into the national level?
I think I can answer the question because it was asked. So I think so. I mean, again, I think that healthcare is bigger than the cost of prescription drugs and of insurance premiums. I think it is behavioral health. I think it's addiction. I think it's violence. I think it's environment. So one of the things that I look at my district and our counties, the Baltimore and Howard County area, we know all about the floods in Ellicott City and Elkridge and other places. You may or may not know about how much folks in Catonsville and Oella are getting sewage backing up into their homes every time there's a huge storm. We know and we hear about Baltimore City, water main breaks, like every 2 weeks. And then again, the same week that Lansdowne High School, or the same day Lansdowne High School had their heat down, there was a water main break on Frederick Avenue right there in Catonsville at the beginning of restaurant week, okay? So we've got real infrastructure problems, and I know I listen to people at the federal level talk about, on both sides of the aisle, the importance of infrastructure and rebuilding. And they usually are talking about roads and stuff like that. Well, I think the federal government needs to do a deep dive Marshall Plan, highway type 1950s, national highway type of project to rebuild our water and sewage infrastructure. And that's the kind of thing that needs to be done nationally based on the aging of the infrastructure in the communities and simultaneously, so that right now Baltimore County and Howard County are each going through their own things different from Baltimore City. I heard at one point that the pipes that Baltimore County was putting in were, say, this large, but the ones in Baltimore City were this large. Sooner or later they have to come on together, right? And so if we're not systemically approaching that problem, then we're really not going to have the cost savings and the sustained solutions that we need. So we know what happened in Flint and how horrible that was with the water, but we also know that the water that's being piped into our buildings is also tainted by lead. So most of you have been in some school somewhere, some building where there's plastic over the water fountain, right? Because you're not supposed to drink from the water fountain because it's got lead and other things in it. So that's a healthcare issue. That's a healthcare issue. Sewage backing up in your home is a healthcare issue. So I do think it translates because frankly, everything's a healthcare issue. At its bottom line, if you want a healthy nation and healthy communities, you've got to look at things from that lens. And the value for me of training as an engineer and the value I see in being in Annapolis as a physician is I do tend to look for root causes. And I think it's also my bias as a surgeon. So I never wanted to be like in internal medicine and go, oh, you got high blood pressure, we're going to put you on this, and we're going to monitor and modify it. I want to find it, cut it out, throw it away, sew you up, get you healed and out the door. I don't want to keep going over the same stuff. And I know that's a little, naive to think that there are any social or political problems that we can solve for the long term, but I do believe that if we're more deliberate in looking for the unintended consequences up front and willingness to address that, and I do think that the greater the diversity of voices in the room, the greater the chance that you're going to have of coming to solutions that you might not otherwise have come up with. And for me, we've got 435 members of the House and Congress. Those 17 are physicians. So, and I've talked to my colleagues and said, a lot of this lies on us. Because frankly, physicians have looked at political service or politics or public service as something to sneer at. We're better than that. And we take care of people, and the work we do is a lot more important than that, and we're busy people. And so we have allowed the voice that we uniquely have as advocates for people. I mean, we're people who interact with people where they are in sometimes the most painful times of their lives. We know what happens when social networks fall apart, and what happens when people fall through, because that's what we deal with, not just the people who are doing well. When the NRA pushed back on an ER physician for commenting, I guess, in support of the kids from Marjorie Douglas, and this guy said, "Stay in your lane," and she tweeted back, "This is my lane," right? And it started a movement. So what I'm saying is, when physicians, and it's true for other professions too, but I think particularly for us, when we demur and don't get involved in the conversation, there is a huge amount of information about what people have to deal with that gets left out of the room. And I think it's really important that that be part of the discussion when we have so many issues that feel like they're really critical in this moment. And as a colleague has said, it's not that there are ever any people who don't have a voice. Everyone has a voice, but some voices are just louder. And I think that as physicians, we're in the position of speaking up for other people, and we don't often take the advantage of doing that. Thank you. All right. Other questions?
No, I can stand up and yell. I'm sorry I came in late, so if I'm asking a question that you've already answered, just tell me to sit down. Are you going to keep your practice?
Yeah.
Yes and no?
Probably not.
Probably not. She said, no, I'm not done.
If so, it'll be a very small concierge practice, but I can't move forward thinking that I would keep it open.
Because it is a full-time job.
Exactly.
Both.
Right.
I mean, you.
Right. So that's why the answer is no.
Okay. And I'm curious about some other issues which escape my mind right at the present second, but you said no.
Yeah, that is, I can tell by the.
Do you have a background
If I know you, I
in
can tell by the place.
practice? I'm not in practice, but in politics.
Other than the last 5 years.
Yes, that doesn't count.
Oh, my background is the last 5 years
Last 5 years, where?
in the General Assembly,
Oh, for heaven's
In the General Assembly. So you are an Assembly member.
right now.
And have you proposed various projects that you have, that have passed bills every session. And you've answered all this, I can tell by the people looking at me like, where the hell were you? Not me.
And that's a good thing.
So you do have 5 years of practice, and do you present material in the same manner that you did here
No, and he's,
to the legislature? Yeah, oh, sure.
where has he been?
I got it back here.
He's very uninvolved.
So I will tell you, if you want to know about my or any of your state legislators, what bills we sponsor, what bills we co-sponsor, and all that, there is a wonderful website. MGA for Maryland General Assembly, LEG for legislators, so MGA, LEG, and then, no, I don't have a handout for that. I can show it to you later. If you put it on, in fact, I'll put it on your phone. And you can go up there, you can look folks up, you can look up session by year, and find out what bills were introduced by committee, what bills were introduced by particular legislators, what was passed, who co-sponsored. The only problem with the system is if a bill is introduced and it doesn't come out of committee, you won't see the amendments that the sponsor may have tried to put on. And the legislative process is not just put a bill and see to get it passed, it's actually try to work it through. So often the bill sponsors will try and make the bill better. The other thing is that even if I didn't have a record, part of the duty of being in the legislature is not just passing bills, but it's trying to make things better. And sometimes that means that it's somebody else's bill that you're improving on. Sometimes, and more often than not, it means you're stopping bills. So you want to stop the bad ones. And it can be participating in different commissions and groups that are working on. So it's not just about, how many bills you introduce and how many bills you pass or don't pass. There's a lot more to the job, including being president of the community. So constituent service is a big part of the job at the state level, and I'm sure it is at the federal level too, which is, answering the questions like, my bill's too high, what am I gonna do about it? Or I can't get this benefit for whatever. So that's a lot of what we try to do as well. And I think my record on that is pretty good. You could always do a little better, but we try to prioritize constituent service.
The other question I was gonna ask is, what is this gonna cost?
What, Kerwin?
The various things that you talked about, things that needed to be done.
Yeah, it's gonna cost a pretty penny. It's gonna cost a pretty penny. So, you get what you pay for, and you try to be efficient about how you spend your money, and make sure that you have the accountability to know what works and what doesn't work, and when you find things aren't working, that you stop doing them. And you look at outcomes. So to that point, yesterday our briefing in Health and Government Operations was from the University of Maryland, where, as you all probably recall, last year we discovered that there was a lot of self-dealing going on at University of Maryland medical systems. And earlier in the year, after the tragic death of Jordan McNair, we found out that the big university was not doing what it needed to do for the students who were entrusted to them as athletes. And then, of course, there was a mold problem, and one of the young people died because of mold exposure. So there are a lot of problems in the system, and so one of the things we do on government operations, we have some oversight responsibilities of trying to make sure that they're accountable. And the question that I asked yesterday, as the new CEO of University of Maryland Medical Systems and the new board president came before us, and they talked about all the new policies that they've put into place and all the new practices. What I wanted to know, because there's nothing to make me think that the people who were on the previous board were not quality people. Quality people can get into bad habits. And so what I want to know is not do you have different policies, but that you have different policies and ways of making sure they're followed. And that you have a cultural change that allows people who work within the institution, when they see things, to say something if it's not right. And that you're not just assuming someone else has taken over it. So the culture has to change. And to his credit, the new CEO said they had a culture problem, and it was going to take a cultural change from the top down to make sure they didn't fall into the same problems again.
I have a comment, and my comment is, I think you're doing a great job in the
Thank you.
legislature, I really do. The bills you've passed, your whole stance is just great. And we all appreciate
I
it.
appreciate that. Thank you.
Thank you very much.
Thank you.
Really, it's hard to say anything other than your enthusiasm, your experience, and the ethical stands you take are very, very appreciated.
Yes.
And I appreciate you all for having me. Can I just say one more thing?
Yes, of course.
So again, I want to point out that I think that as a member of this legislative district, I'm very fortunate, as are you, to be represented by Clarence Lamb as our senator, and Eric Eversole as one of our delegates, and Jessica Feldmark. We work hard as a team. We work hard individually, and I hope that you're comfortable reaching out to any one of us, or at least that there is at least one of us that you feel comfortable reaching out to. And it's a privilege to serve you, and you guys make it fun.
I know you are very generous with your time, but it's getting late, and I know there are people who need to leave and they don't want to be rude and stand up while you're talking. And I'm certain that we can grab a few minutes for people who want to come forward and talk a little bit.
And I'll put that website on your phone.
Again, thanks for coming.
Thank you all.
Thank you.
Thank you.